It sounds good.
There's Dr. Adekari. As we got to see his hands, it was very important. Welcome, Neil.
How are you, Dave?
Fantastic. So I think we're starting to let everyone in. So we're just going to let everyone start coming in as in our usual fashion. We will be starting the presentation in about 1 to 2 minutes. So we appreciate everyone's patience with this. The process will be a little bit different in the near future, as I suspect you'll be able to let people in quicker and easier, but we welcome everyone. So we'll give it another minute. And I'm rambling on here a little bit, just like it's radio, because the worst thing in radio is to have quiet, because everyone will start wondering, is it coming on? So we'll give it another minute.
I assume you will.
Yeah.
Everybody will be muted unless they're speaking, I assume. That's up to them individually, right?
Well, that and Maria and others will often effectively mute people. Anyhow.
Yeah, sometimes someone is on, you hear background noise sometimes.
Absolutely correct here. Anyways, we're going to get started right about now. Good afternoon, everyone. I'd just like to welcome everyone for today's OC3PR from Critical Care Services Ontario that will be examining COVID-19 vaccines. Before we get to this very important topic, some things for everyone to keep in mind. If you have a question that you would like answered today, please send it to Q&A. They'll do their best to get it answered, time permitting. Today's Q&A are being fielded by Dr. Neil Adekari and Dr. Jose Terrio. As always, we ask you to do your best to keep yourself muted. If you have any ideas or suggestions, please send them along to the email address info@ccso.ca. As they do influence what we present, we encourage you to also follow CCSO on YouTube and Twitter and to visit their website. I'll remind all of you there's actually an opportunity to send in your questions ahead of time before a talk. The practice of sending these questions in ahead of time will likely become invaluable, especially for our next special webinar this Saturday, where we are planning on presenting the emergency standard of care topic. This explores the difficult subject of when there are challenges of providing care to all patients in the setting of a massive surge in patient numbers. Finally, we truly value you taking the time to fill out the evaluation survey at the end, as it will help us refine our webinars for future events. When the COVID-19 pandemic began in earnest in the early months of 2020, discussions already began on vaccines, as many would recall. The idea of having a vaccine before the end of 2020 was deemed to be a near impossible dream, as the fastest possible times were thought to be around 18 months. Thus, when Pfizer and then Moderna had vaccines available before the end of 2020, it was an amazing achievement, but also brought about many questions along with several unique challenges. With multiple vaccines in the pipeline, the issues are likely to only increase. To help us begin to address this, we are pleased to have with us today Dr. Roger Sandre. Dr. Roger Sandre is an infectious disease specialist working at the Sudbury Health Science North for over 20 years. He completed his medical degree and internal medicine training at McMaster University before embarking on his infectious disease fellowship training at the University of Alberta. He's currently the medical director of several programs, including the Antimicrobial Stewardship Program, Infection Prevention and Control Program, or IPAC, and the Regional HIV Program for Northeastern Ontario. He is an assistant professor at the Northern Ontario School of Medicine, or NOSM. The objectives for today are to explore the differences between the various vaccines that are or likely to become available, the safety issues of these vaccines, strategies of vaccine programs, and what the recommendations are for expected behavior post-vaccination. And if time permits, They'll talk about variants, including the infamous Sudbury variant we just heard about. Obviously, lots there for you, Roger, and we thank you again for agreeing to do this. I'd like to welcome you to OC3PR and for taking the time to discuss the infamous V word, as it's now becoming, vaccines for COVID-19. So over to you, Roger, and thank you again for joining us.
Okay, thank you very much, Dave. Yeah, thank you, Dave, and thank you, Jose Terio, for inviting me to speak on this critical care webinar on the topic of COVID-19 vaccines. It's a huge topic. I'm going to try to cover it in 20 to 30 minutes. And we need to do this to build confidence, really, in vaccination, in the healthcare field and in clinics. And it's critical in these settings to set proper expectations, ensuring vaccine uptake, and helping to protect ourselves and protecting our communities and our patients. I'm going to go through a number of topics. They're listed here, and I'm going to try to address most of them as best I can, and address questions near the end. And there are many unknowns still in the vaccination world with COVID-19. So this is an unprecedented time. I mean, as Dave mentioned, we've witnessed a global pandemic with the SARS-CoV-2 virus and rapid development of a vaccine within 1 year, from basic research through clinical trials to vaccine rollout. So it's really been unprecedented in vaccine development. It is important to understand some of the basic science around these vaccines. There are three major types of coronavirus vaccines currently, and here they're listed here. The first type are protein-based vaccines, and this is really where you've taken the spike protein on the surface of the virus, which is where the immunology occurs and antibodies are produced against the virus. So vaccines can be developed by taking these protein spikes and putting them into a vaccine and delivering them. And there are many vaccine developers that are doing just that. The second way is to use a viral vector. This is your traditional form of vaccine development, where you take the genetic material involved. In this case, it would be for the spike protein encoded on a small piece of DNA in an adenovirus. In most cases, that adenovirus is then delivered in the vaccine into ourselves in the form of a vaccine, and then delivered into our own cells, where then messenger RNA is used to transcribe it into spike proteins, which are expressed on the cell wall, and our immune system is activated, producing antibodies and activating different components of the immune system. The other form, which is fairly new, quite new, is the use of messenger RNA. So the messenger RNA itself, instead of a virus, they have taken the messenger RNA, encoded the spike protein, and it's encapsulated into a lipid nanoparticle, given in a vaccine, and then delivered. And that then attaches to our cells, incorporates the messenger RNA into our cells. The messenger RNA itself is rapidly degraded, but it triggers protein production of the spike proteins, which are then expressed on the surface of the cell, and then our immune system is activated. So all of these vaccines are designed to deliver immunity against the spike proteins on the surface of the coronavirus. That's the basic premise of the technologies of vaccines in this regard. Now, there are many vaccines being developed worldwide. And of course, these are viral vaccines, vector vaccines, nucleic acid with a messenger RNA, and protein-based. And many of these are coming down the pipeline. I'm going to focus on three vaccines today and just review briefly the trial results in each of these studies. The Pfizer vaccine and the Moderna vaccine are currently approved in Canada. Their results were published in the New England Journal of Medicine recently. And the third vaccine is the AstraZeneca vaccine, which is a viral vector vaccine, not yet approved in Canada, but coming soon. There are others as well, but I cannot present those because of time constraints right now, and they're not currently approved in Canada anyhow. So the first two vaccines I want to spend time on, the Pfizer and the Moderna vaccine. These are available in Canada. These trials were randomized, placebo-controlled, multi-center studies, two-dose vaccines in adult patients only, and they excluded individuals who were pregnant, breastfeeding, any known history of active COVID and immunocompromised patients, except stable HIV patients in a small group in the Pfizer trial, which were excluded from their primary analysis. But basically, these trials were large, 30,000 subjects in each trial. These are basically trials that were 10 times larger than your usual vaccine trials. Both were analyzed for safety data in 2 age groups, and usually their safety profile after 7 days after both dose 1 and dose 2. So the first trial is the Pfizer vaccine in the New England Journal of Medicine. And these are the study results. Basically, they divided patients into two groups, those who received vaccine, those who received a saline placebo, and this was over 18,000 patients in each group. They were mostly white individuals aged under 55 or over 55. And it should be noted importantly here that 42% of these patients in this trial were over the age of 55. They excluded, of course, those that were pregnant or immunocompromised. There were 196 stable HIV patients, which were not in the primary analysis. These are the results of this trial. And just pay attention to the areas that I've circled in red. And this basically is looking at the overall efficacy of the Pfizer vaccine, which showed an efficacy of 95% overall. And when we look more closely at the numbers, you have to realize there are over 18,000 patients in both arms, the vaccine group and the placebo group. In the vaccine group, there were 8 COVID infections. And it should be noted that only one of those developed severe infection. In the placebo group, there were 162 cases, of which 9 of them developed severe COVID infections. So not only did the vaccine prevent infections in 95% of the time, but even when infection did occur, there was a high efficacy for preventing severe disease. They also looked at vaccine effectiveness across groups. So in other words, across age groups, sex, race, and the different countries. There were 4 countries involved in this trial. Though the trial was not powered to show significant efficacy in the groups, the numbers really were fairly equivalent across all the groups in terms of effectiveness. This is an interesting slide, and it really shows the curve and the divergence in the curves between the vaccine group and the placebo group. The placebo group is in blue. The vaccine group is in red or orange, and it's fairly flat. So you can see from time 0 going forward, the number of infections occurring in both groups. And the divergence is astounding in terms of results. But also what's interesting is at day 12, and this is the small graph at the top, at day 12, the curves start to diverge. And you have to remember that the second dose of the vaccine is not given until day 21. So the vaccine effectiveness is starting to be seen even after the first dose. And when they looked at analysis of the Pfizer study, there was about it depends on which numbers you look at, but about a 52% effectiveness even after giving 1 dose. Oops. All right. Is there a scratch on the screen there, Dave?
It would be on yours if there is. I don't know.
I don't know what that is. All right, I must have moved something, but there's no other lines on top of this slide, eh? Does that look clean?
They're still there, unfortunately.
The lines?
Yeah.
Sorry about that. I don't know what happened there.
Maybe your mouse, but
no, I didn't touch my mouse. I don't know why that would be. Okay, sorry about that. Just ignore that. In terms of looking at side effects, I'm showing the side effects here between the 2 age groups, under 55, over 55, and the 2 doses given. And really, a lot of patients developed a lot of local pain at the injection site, but they were mild, lasting 1 to 3 days, and then an array of different symptoms: fevers, fatigue, headache, chills, vomiting. These were usually mild, lasting 1 to 3 days in the majority of patients. I did not show the placebo side effects here just because of time and because of sheer numbers, but there were individuals, of course, in the placebo group who also developed side effects from local pain or systemic reaction. Okay, so that was the Pfizer study. This is the Moderna study. This is also a messenger RNA vaccine, similar to Pfizer, 2 groups, 15,000 in each group. It was not multinational. This study occurred only in the United States, predominantly in white individuals. And the age cutoff here is different, the way they analyzed their data. They used 65 years instead of 55, like in the Pfizer trial. Median age was 51. And once again, the 2 groups were pretty much identical in terms of age distribution, ethnic background, chronic disease states such as diabetes, lung disease, heart disease. They were pretty much equal. If you look at the results again, and these are the areas circled above, there was 94% efficacy between the placebo group and the vaccine group. And of those in the placebo group that developed COVID, there were 185 patients. 30 of them developed severe disease. This is in the placebo arm. If you look at the vaccine arm, there were only 11 that developed disease, and 0 out of 11 developed severe COVID. This vaccine was basically 100% effective in preventing severe disease. They also looked at overall efficacy amongst groups. Even though it was not powered to do so, it was basically the same going all the way down, whether you looked at males or females, ethnic origin, age. The only one difference that I noted was that over the age of 65, the efficacy dropped a bit down to 86% rather than 94%. Here is a curve similar to Pfizer's. Divergent curves starting at about day 14. And you can see here, even after 1 dose, remember the second dose isn't given until day 28, but even after day 14, the curves start to diverge. And when they went back to look at, analyze some of this data, the Moderna vaccine was about 80% effective after the first dose, going up to its 94-95% efficacy after 2 doses. So once again, impressive results. Side effects, similar. I'm not going to spend a lot of time on here. They divided patients into under 65 or over 65. Side effects of the Pfizer and the Moderna vaccines seem to be higher in younger people and were also more common with the second dose. Also mild in most cases, resolving after 1 to 3 days. These are the vaccine components in these 2 currently approved vaccines in Canada. Pfizer and Moderna vaccines do not contain any food products. There's no peanuts, there's no milk, there's no eggs, there's no antibiotics in these vaccines, there's no animal products in these vaccines. The one component, non-medicinal component, which individuals talk about is PEG, polyethylene glycol, and an allergy to PEG. Most people who have an allergy to PEG know about it because PEG is found in a lot of other medical products, laxatives, Tylenol. It's found in some antihistamines. It's found in a lot of other products, even contact lens solutions. So the allergy to PEG is actually rare. And most patients who are allergic know it. The last trial I want to talk about is the AstraZeneca vaccine trial. This is not approved in Canada. It's approved in the UK. It likely will be approved in Canada shortly, as far as I understand. This is not a messenger RNA vaccine. This is a viral vector vaccine where they have taken the virus and they put it into an adenovirus, which is inactivated, that is unable to replicate. And through that means they deliver the DNA into our cells, into messenger RNA to produce spike proteins. They did not use a saline placebo. They used a control in the form of meningococcal vaccine because they wanted to give a more of a true vaccine to the control patients. Their vaccines were given on day 1 and 28, only in adults, over 11,000 patients. Demographics were the same across both groups, and the trials were a little bit more complex. In simple terms, there were actually 4 trials, and the results published so far in the Lancet is the composite of 2 of those trials, which I will show you here. And this occurred between Brazil and the United Kingdom. In Brazil, they enrolled about 4,000 patients, and the efficacy of the vaccine between the control and the vaccine group was about 64% in preventing COVID-19. If you look at the United Kingdom, there were about 4,800 patients in this one arm. The efficacy there, very similar, 60%. Now, the controversy comes in this vaccine in this last group at the bottom. 2,700 patients accidentally got half a dose of vaccine for their first dose, but not their second. They went back and corrected this, but all of these patients only got half a dose for their first, but the efficacy was 90%. They do not have a good way of explaining this. And in fact, there's a lot of individuals working on this, trying to explain why the efficacy would be 90% with half a dose and less with full dose. So nevertheless, they were allowed to go on and pool the data. So they took all of that data, they pooled it together, and between Brazil and the UK, there were 131 positive cases overall, 30 in the vaccine group, 101 in the controls. 0 of them in the vaccine group developed severe disease. 2 developed severe disease in the control arm with an overall efficacy of 70%. Now, this trial has been criticized because of some of these differences and unexplained differences. And some say that really they should repeat their trials. But nevertheless, they've gone ahead and they have sought approval, and they've received approval in the UK. So it's an interesting finding. Once again, if you look at the curves of this trial, divergent curves of those that develop COVID-19, those that received the meningococcal vaccine, which was their control, is in the blue. The vaccinated patients for COVID-19 is in the orange at the bottom. And you can see that the curves diverge quite rapidly after giving the vaccine. This is just a comparison of the AstraZeneca and the Pfizer vaccine in terms of side effects. I'm not going to spend a lot of time on this. It's a lot of numbers. Both groups developed, of course, a typical side effects you'd expect to see with a vaccine, which is really your own immune system, your own body developing immunity against the virus, and that's a normal reaction. There have been a few idiosyncratic things happen, such as a case of hemolytic anemia in the control group. There's been a few cases of transverse myelitis in the vaccine group with the AstraZeneca vaccine, but they deemed these idiopathic and unrelated to the vaccine. Ongoing studies are being done and follow-up as well. So when you look at these 3 vaccines very briefly, side by side, Pfizer and Moderna are approved in Canada. AstraZeneca is coming, and there are others as well. Pfizer and Moderna are messenger RNA vaccines with an efficacy of 94 to 95%, very large trials in adults over the age of 16 or 18. AstraZeneca is a viral vector vaccine. It is not a live attenuated vaccine like other vaccines. It's inactivated. But over 11,000 patients, 70% effectiveness, and the side effects are very similar, really, in the different with the different products. Moving on to some of the rollout of vaccinations in Ontario. As of January the 18th, there were about 240,000 cases of COVID-19. These go up daily, as everyone knows, with about 221,000 cumulative doses of vaccine being administered. 14 out of 34 public health units have yet to receive shipments of vaccine. And if you want to know more about local case counts and vaccine rollout, there's a website link at the bottom if you want updates on the rollout and the number of cases on a daily basis. So this is really an evolution. Every day it changes. This is the overall plan of vaccine distribution, and some of you have probably seen this. I'm sure you've seen it on the news. This is continuously being talked about in terms of 3 phases of rollout. We're currently in phase 1 between now and into the spring, where those in high-risk populations are going to be vaccinated first, including the elderly, living in nursing homes, retirement homes, healthcare workers, First Nations, and hopefully adult with chronic home care recipients, and then moving on to phase 2 and phase 3. And I think really, in reality, a lot of this is in evolution as vaccines are rolled out and as availability goes up and down. There was a study with Statistics Canada looking at Canadians' reasons for not getting the vaccine, and most of these reasons are that they're either not confident in the safety of the vaccine or they're concerned about side effects predominantly. And this is true of really any vaccine. There is no long-term data on these vaccines, obviously, because they're so new, but certainly they appear safe in the studies. The United Kingdom has adopted a little different strategy when it comes to vaccine rollout. The biggest difference is the timing of the 2 doses. Of course, Pfizer and Moderna vaccines are timed 21 and 28 days after the first dose. And because of vaccine supply, the UK has increased that interval of time up to 12 weeks, which is probably the biggest limit you're going to want to give. There's no data on doing this, but you do have to realize that in most of these trials, there was the ability to delay the second dose, and not all of these patients were given their second dose exactly as timed. And in fact, in the AstraZeneca trial, they had difficulty with vaccine production, and many of their vaccines were in fact delayed much further than the recommended dosing schedule. So these vaccines are safe. There's 2 messenger RNA vaccines available in Canada. No serious side effects so far within 6 weeks of vaccination. Side effects are a sign of immunity. They were developed rapidly, probably because they were able to avoid a lot of the bureaucracy and red tape involved with vaccines. And peak immunity occurs about 7 days after the second dose. But there still are many unanswered questions around COVID-19 vaccination. The vaccine is not for individuals who are severely allergic to previously administered vaccine or to components of the vaccine, such as PEG. But once again, those allergies are not common. You cannot vaccine someone who has active COVID. You should not vaccinate someone who's also receiving another vaccine, such as Shingrix or influenza, and likely wait 14 days to do so, and not vaccinate those who are outside the authorized age groups. Bell's palsy has been a question that's been asked. There were a few cases of Bell's palsy in the Pfizer and the Moderna vaccine groups, not thought to be due to the vaccine itself. The normal rate in society is about 1 in 10,000, with about 40,000 cases of Bell's palsy usually in the United States per year. So this is not thought to be related at this time. People do ask about infection versus vaccination, which is best. Vaccination is safer, offers better protection than natural infection. COVID vaccines uniquely expose people to the spike protein to give a very specific immune reaction. And there's examples of better immunity from vaccines as opposed to natural infection. This is seen with HPV vaccines, it's seen with tetanus, and it's seen with pneumococcal vaccination. There are variants of the virus as well, and this has raised questions about the effectiveness of the current vaccine. There's the UK variants, which are now found in 60 countries. You could pretty much consider the UK variant distributed worldwide. Over 25 cases in Canada have been reported, likely grossly underestimated. And these variants are variations in the spike protein. The vaccine, though, these vaccines do not work against just one component or one domain. They work against multiple domains on the spike proteins. Researchers believe that currently, the current vaccines should be effective against these variants, but the most problematic variant probably is that found in South Africa because of the sheer number of domains that have been changed. So I think time's going to tell whether or not new vaccines need to be developed going forward against some of these variants. These variants seem to be more transmissible, but not more virulent, as far as we understand so far. So there's more information coming out on this on a daily, weekly, monthly basis. So I'm probably going to end there, Dave, and take any questions that might be coming.
Well, Roger, that was fantastic. I certainly learned a lot, took some notes. I really think it was quite important to have heard that the trials are 10 times larger than most vaccine trials. I don't think that point gets emphasized enough. I'm curious what your thoughts on. They're called efficacy trials. I actually almost think they're more effectiveness trial, like what happens in the real world. Any idea on antibody generation from these? And when you hear about the failures, I often wonder, is it a failure of the vaccine or did they not mount a response? And I don't know if you've seen some of the not commercials, but the news highlights where they're showing injection, and the one that made me just kind of shake my head is when you see the fluid squirt out because the needle wasn't on properly. So what are your thoughts on that? And then we'll go to Jose and Neil for other questions.
Yeah, well, and antibody responses. Well, good question. These trials weren't designed to look at the follow-up on serological results or antibody titers or antibody responses. There were, I'd have to go back. One of the trials did look at serology at baseline in some patients and then going forward with vaccination, but the numbers were very small. So we don't have good information about that. We do know that in regards to serology, well, first of all, it's not readily available to do serology, blood serology on individuals. And even if you've had COVID, it's still recommended you get vaccinated. So no, we don't have good information about we don't have good information about the lasting immunity of vaccination and the antibody response that's generated. We just don't. We don't know if this immunity is going to last months. Are we going to need revaccination on a yearly basis because the antibody levels drop? So I don't have further information in terms of specifics with antibody levels. These were not really analyzed in the studies.
No, not to put you on the spot like that.
Yeah, no problem.
I guess, if you were a betting man, would you say that boosters are going to be required going forward?
I think so.
I share that. When you hear that people lose immunity to coronaviruses, which maybe someday you can explain to me how that happens as opposed to some of the other viruses. But especially with the variants coming along, I think we're going to see further strains of the virus similar to influenza. I think we are probably going to require boosters or yearly vaccination is my feeling on it. I'm not an immunologist, but I mean that's my thought on it. Okay. No, you're not alone in that. Jose, do you have a question to do, and then we'll go to Neil for the next?
Yes, thank you. Thank you, Roger, for this excellent presentation and for taking the time. One of the questions that pop up in the chat box is comments on immunocompromised patients receiving vaccination. Is there any information on the doses they receive? Is there any suggestion on following up with serology? I know that we're still at the beginning and some of these studies did not look and did not include these patients, but your thoughts?
Yes, immunocompromised patients. Good question. And this is posing a dilemma for many who work in the medical field where we deal with immunocompromised patients, myself included, because I have an HIV practice with that population of people. I think the general, obviously these trials did not include immunocompromised patients. Patients on chemotherapy, patients on biologics, patients with cancers. There were only about 196 HIV patients in one of the trials. They seemed to do fine. Those were stable HIV patients. But I think the general consensus amongst experts, as far as I understand, is that the vaccine should be safe in immunocompromised patients. These are patients on biologics. These are patients on steroids. These are patients on immunosuppressive drugs, and in the HIV world as well. But the big question is the level of immunity, and is their immune response going to be blunted because of their underlying immunocompromised state or immunosuppressive drugs? But there's statements that have come out from the Canadian Rheumatology Association, the Canadian Gastroenterology Association, the Canadian Society of Transplantation as well, which basically say that support the use of the vaccine in their patient populations, discussing with the patient the risks and benefits, obviously, and that there may be a decreased immune response. Right now, I don't believe there's a recommendation from any of these groups regarding an increased dose of vaccine to be given, either first dose or second dose. And we don't really have a lot of information in this group. But I wouldn't hesitate to vaccinate my HIV infected population, for instance. I'm recommending that if vaccines offered, to get it.
That's great. Thanks, Roger. Neil, do you have a question?
Yes, I do. A couple of related questions around the timing of vaccination relative to two issues. One would be relative to the timing of dialysis exposure in patients that have end-stage renal disease and that are on dialysis.
Oh boy.
And the second, and maybe there's no data on that. And the second would be timing of vaccination relative to a patient who had an acute medical illness of some sort and was in the hospital. Like when would you vaccinate such a person?
Well, for the first question with the dialysis, I really don't know. I haven't read anything on that, to tell you the truth. I don't think there's any information on that whatsoever. Obviously, there are patient populations that are going to be at high risk for COVID and complications. So that would need to be discussed individually with patients. They may have, I think they may have a bit more of a blunted immune response because of their state, but there's no information on that, unfortunately. I don't really know what the nephrology societies say about that. I haven't had time to look that up, so I just don't know. In regards to sorry, what was the second question? That was the
patients that have had an intercurrent medical illness.
Oh, right. Yeah, I mean, like any vaccines, it's generally recommended you delay vaccination until their current illness is resolved, of any acute illness. I wouldn't vaccinate until that's gone. You wouldn't be able to tell sometimes the differences between side effects, for instance, is one thing, but you generally do not vaccinate individuals who have an acute illness, including COVID-19. If a patient has had COVID-19 and has then become asymptomatic and is over their illness, it's recommended to vaccinate.
Okay, thanks, Roger. Jose, do you have another question, or
Yes, I do. We have a question on how would you address the hesitancy on vaccination, maybe with your population and your patients? So how would you, if you have any tips to share, how do you express that to your patients?
Well, I would, it depends on what their concern is, specifically. If it's around safety, I basically explain to them the information that's available on it, and I present it to them, and try to reassure them about that, and just exactly the same sort of information I presented to you, but in a more of a layman's term in terms of safety. So that's about that. I mean, that's what I do when I've discussed it. For instance, with my HIV population, they've all been fine with getting vaccinated as soon as they can get the vaccine. So it's really explaining the facts. You're always going to have in the whole vaccine world. You're always going to have people that you're not going to be able to convince one way or the other, no matter how hard you try. I think sometimes looking at the components of the vaccine is very helpful. The vaccine has been deemed safe amongst religious communities, for instance, if that's their concern, amongst the Jewish Council, the Muslim Council, completely safe. It does not contain animal products. It doesn't contain antibiotics. So do you reassure them of this? Many don't know the components exactly of the vaccine and what's in there. So it's basically explaining the facts, I think, and the effectiveness. I mean, these trials were huge. These trials are impressive. You can't. I mean, give me another vaccine trial in the last 20 years that has been this impressive. And one of the things people are a bit worried about is that it was too rapidly developed. I would say that these trials were done quickly because they avoided all the bureaucracy and the red tape that's involved with our usual slow development of vaccines. So we are so used to developing vaccines slowly that when something is done properly, it looks like it's rushed. This may set a different standard and benchmark for how things probably should be done. So we're very used to vaccines taking 10 years to develop, and all the bureaucracy that things have to go through. So that's the way I look at it anyways. I try to just reassure them of some of that information.
Well, if we were looking for a sound quote, I think that might be it for this one, because I think you're absolutely right. And that's really important for people who are concerned that it's been rushed. I think I couldn't have said it better. Neil, do you have another question, I believe?
Yes, I do. This is someone who is saying that she basically had no side effects from the first dose of the vaccine. And is there any evidence that the absence of side effects means that you're not going to be as protected as if you do have something, even arm pain?
Yeah, good question. I don't know. I don't know if anybody really knows that. We certainly, because I don't know of any information looking at the immune response with antibody levels. There's no information as far as I know looking at immune response and relating that directly to the side effects to the vaccine or this vaccine. We do know that generally the side effects are a good thing, and that means you're developing an immune response to the vaccine. I can't back that up with information and numbers though. I don't have that.
Along those lines, Roger, the fact that people get more side effects with the second one, is that perhaps not a way of just saying the first one actually generated an immune response such that when they are exposed to it a second time, that's why they're experiencing side effects, as opposed to that's telling you that you will react. I don't know what your thoughts on that.
Yeah, I agree. I think you've triggered the immune response. You've triggered those memory cells, and then you trigger them at the second time when you've given the second dose, and you have a larger immune response, which is actually a good thing. Yeah. I think that's probably a plausible explanation for that.
Especially when I hear the timing of it, that people were experiencing it almost that evening or later the next day. It would be hard to think something different to that effect, but likewise, not an immunologist. Jose, do you have any final questions there for Roger?
Yes, I think we're getting multiple questions, but unfortunately time limits us. Two small questions. One is a little smaller. Vaccination in children. What do we know? Is there anything coming? And the second one is just questioning the Pfizer and Moderna trials in terms of looking at the number of cases even in the placebo groups. So comments?
Well,
Like the numbers of cases in the placebo group were still small.
yes, they were. I can show that again. First of all, in regards to children, no, there's not data. There's no data in children, but trials are being done. There's no information about that yet. One of these trials was down to age of 16, so it's not indicated in children, but there are trials being done in children. One trial is between I think age 12 and up, and other trials, but we need to see that. We need to see that data. So no, there's no indication right now for vaccinating children. The placebo, yeah, the numbers in the placebos, if I go back here to the, for instance, well, you're talking about Moderna and, yeah, so for instance, this is the Moderna trial. And here, even amongst the placebo, there were, amongst 14,000, there were 185 cases. So the question is, the numbers are still small, even in that group. That's the question. Is that right?
Yes.
Yeah. True. It is. Yeah. You don't have a lot of cases there, but the differences are huge.
And the efficacy
between vaccine and placebo amongst the same population. Now you have to, you also have to realize that these trials, and I don't know if this plays an important part or not, but these trials were also done in an era of, and possibly in a population where there is masking and distancing as well. So you're doing this in an environment of masking and distancing and other issues. If you take that away, what would the trials look like? And we don't know that. So,
but the efficacy or the effectiveness of the vaccine is measured against the cases from the placebo. So it still reduces.
It's still within the same group, and the groups were pretty much identical. I think what's even probably more impressive is the reduction in severity of disease. And people do not realize that, oh, well, COVID's one thing, I just don't want to get COVID. But if I do, well, I do. There are many people who get COVID and have long-term consequences of their COVID, even if they're young. Memory problems, concentration difficulty, ongoing fatigue. They may not have died of their COVID, but they've got ongoing problems. So if that severity can be reduced, even with vaccination, that's a huge win. So I'm really impressed by the reduction in severity of disease as well. Not only by the sheer numbers, but it preventing severe disease.
That's great, Roger. Neil, do you have a final question or two for Roger?
Sure. There's a question about the concern that some people have had about antibody-dependent enhancement with vaccine. And I wonder if you could talk a little bit about that and what you would say to those people to reassure them.
What do you mean, antibody-dependent? What's the gist of the question there?
I think antibody-dependent enhancement was a concern initially. Potentially the body's response to COVID infection could be less effective or something because of the production of antibodies. So I've heard the phrase, but I can't actually explain what the mechanism is. But this was something that people were talking about initially.
I'm not quite too sure the gist of that question.
I guess to paraphrase a little bit, Roger, the fact that you mount a response with your vaccine doesn't mean if you got the virus, it's preventing you from getting the virus. I don't see how you would get worse disease. And that, to your point that you just said, that disease severity for those who do end up getting it is less, is it not? Is what you've said?
That's what all these trials have shown. Yes, that severity of disease. So I think everyone's going to have, I think, a little bit of different antibody response to either vaccination or innate natural infection. There's I haven't seen clear data relating that to the protection against disease. Like, for instance, these trials didn't look at antibody titers in patients afterwards to see who developed a good antibody titer and who didn't, and of those, who developed severe disease and who didn't. So that data is not available.
I think the way I understand it is, with dengue vaccines, there was a concern that you gave someone a dengue vaccine in some of those trials, and then they actually got dengue and they got super sick, right? But the data here show that, as you've stated, showed very nicely, is that the incidence of severe disease is actually reduced with the vaccine. So it seems not. I mean, the data don't really support this.
Yeah, and I think it's important to note that you cannot get COVID-19 from these current vaccines, not the ones that are released, and not from the AstraZeneca vaccine either. You're not giving a live attenuated vaccine. These are not live attenuated vaccines. So in other words, we're not giving COVID-19 virus that's been attenuated into an individual, which we do give for many vaccines. Like MMR is a live attenuated vaccine, varicella zoster, yellow fever. There's other examples of live attenuated vaccines where they've actually taken the virus that causes the disease, they attenuate it, and they give it to produce an immune response. So these are not those types of vaccines. Even the AstraZeneca vaccine is not a live attenuated vaccine. This is an adenovirus that's been inactivated simply to carry the material to your cells. And you don't get adenovirus either because it's been genetically altered, so it is unable to even replicate. So it's important to note you cannot get coronavirus from these vaccines. And these vaccines do not alter your DNA. And in fact, even the messenger RNA ones, the messenger RNA is quickly degraded, as far as I understand from immunologists, within hours and days, where it doesn't even exist anymore after the vaccination. So from that standpoint, I'm reassured about that.
Okay, that's great, Roger. Just two final questions here. One is about how should people behave in terms of after being vaccinated, in terms of social distancing, mask wearing, and if you can comment on that quickly. Yeah. And I believe Neil will have the final question for you.
Yeah, I got a short slide on that just to summarize that, because I thought that might come up. Oh yeah, so once vaccinated, are masks, distancing, and hand washing still required? The short answer is yes, they are, for various reasons at this point in time anyways in the pandemic. Number one, studies were not designed to show efficacy against developing asymptomatic infections. So you can still have individuals who have asymptomatic infection and potentially still shed. We don't know that. We don't know the data. For now, I mean, not everyone is vaccinated at the same time. Immune response can vary in individuals. It takes time to build up immunity. So for all these various reasons, in the middle of a pandemic, you're not going to see any changes in terms of masks, distancing, and your social and your normal measures you take to prevent infection, not until we start seeing the pandemic disappearing.
Excellent.
For all those various reasons. There's going to be no changes, I don't think, in any of those recommendations right now.
Yeah, and we'll go to Neil for one last question. I just want to remind everyone to take the time to please fill out the survey for the webinar. It's certainly valuable feedback for us. Neil, do you have a last question for Roger?
Yes, many questions coming to me, and I apologize to some of the questioners that we're not going to get to your questions. They're two very related questions, and they're just around the exclusion of patients with pregnancy from the trials, and what you do about that, and the fact that around 80% of the patients in the trials were Caucasian, and what does that and yet actually not being Caucasians in many studies a risk factor for severe disease. What is there anything to say about those situations?
Yeah. First of all, I'll leave the pregnancy question for 1 second. The mix of the patients in a lot of these trials was predominantly white. I think we're going to need to see more trials come out in other countries that includes other ethnic groups for sure, because immunity can vary between ethnic groups. That is true. So that's a lack of information. Absolutely, nothing we can do about that right at the moment. The current vaccine trials were done in their respective countries where they were developed, and that's just the mix for now. So I think we do need more information in other ethnic groups for sure. Absolutely. Secondly, in regards to pregnancy, these trials were not done in pregnant women. They were not done in women who are lactating and breastfeeding. So we do not have data, number one. Secondly, it is felt amongst most physicians in those fields, in the obstetrical gynecology world, as well as statements put out by the Society of Obstetrics and Gynecology of Canada, that breastfeeding most likely is completely safe from what we know of the vaccines, but we do not have data looking at the vaccine levels in breast milk. We just don't. In terms of pregnancy, the advice currently is to discuss that with your patient, looking at the risks and benefits and the risk of COVID-19 in your patient. And as far as I understand from other experts, most likely these are safe in pregnancy, but we do not have the data, unfortunately. It is not recommended to screen women before receiving vaccination for pregnancy, and that's in Canada as well as the UK. So that's about as much as I can say right at the moment. We just don't have the trials in pregnancy. There was a statement from Health Canada that if a first dose of vaccine was given, and then a woman was found to be pregnant between the first and the second dose, Health Canada waffled a little bit on that, and they said you may want to consider the second dose of vaccine after the pregnancy is finished, which I find a little bit odd because that's 9 months later, and we don't have any information on vaccine efficacy giving the second dose after the pregnancy is finished, after they've delivered. So I thought that was a bit interesting, but that was Health Canada's position. But that's all I can really say about the pregnancy. We don't have data, unfortunately. You're gonna have to, doctors will have to speak to their patients individually about it and look at the pros and cons and what's the risk of your patient being exposed to COVID.
Thank you.
Excellent. Well, Roger, fantastic job. You know, I certainly learned a lot, and I'm sure many of our listeners have. I really appreciate you taking the time. I really appreciate Neil and Jose fielding the questions and doing that. And certainly would encourage everyone again to fill out the survey. I also encourage people to send us feedback and comments. We certainly welcome that. And we look forward to seeing you on Saturday, this Saturday, for our special webinar on the emergency standard of care. So Dr. Roger Sandre from NOSM, again, thank you for taking the time, and thank you everyone for participating today. We'll see you soon. Take care.
Okay, thank you. Bye.
Thank you.
Thank you.